Hello, everyone. This is Munmun DeChoudhury. I am an associate professor of interactive computing at Georgia Tech, and I'm very pleased and honored to be a part of this excellent symposium today, and so thankful to the organizers for having me. In my talk today, I'm going to reflect on some of my experiences and potentially some lessons learned along the way as well through two different collaborative research projects in digital mental health. In particular, I'll highlight engagements with two stakeholders in these projects spanning a health system and a federal agency. So, the question of how to address mental health issues has existed since antiquity. The answers have, of course, evolved across cultures and millennia, often adapting as our understanding of the human condition has changed in the face of advances in science, in chemistry, in medicine, psychology, and probably most recently, technology. But if you were to look back, humans have actually tried since the last 7,000 years to cure and treat the mentally ill. The history, of course, is not a flattering one, but it does explain a great deal about how and why the landscape of mental health treatment is what it is today and where it could possibly go next. In the language of Thomas Kuhn, one of my favorite philosophers of science, it would mean understanding where the paradigm shifts have been and what the next one could be. The first paradigm was psychoanalysis. It originated at the end of the 19th century in the work of renowned psychologist Sigmund Freud, and this work was known as a project for a scientific psychology, the goal of which was to furnish a psychology that'll be a natural science. With the invention of antidepressants and eventually antipsychotic drugs in the mid and late 20th century, two paradigms emerged following psychoanalysis. In the first one, clinicians and researchers have begun to use a biological approach in which mental disorders are considered as dysfunctions of the brain physiology, while on the other hand, learning behavioral and cognitive scientists have begun to regard the learner as an active interpreter of the situation, giving rise to the widely acclaimed cognitive behavioral therapy that is often used even today for changing patterns of thoughts that cause disturbed emotional behavior. So, what these paradigms tell us is that we have indeed come a long way from relieving people of quote unquote evil spirits to putting people in asylums or conducting lobotomies on them. But as we know, mind body dualism is a core crux of Western medicine, and therefore a lack of unification between these two paradigms, as well as with a mix of things such as prevalent social stigma, systemic barriers, and deep-seated disparities have often failed our efforts to help individuals with mental illness. This talk will focus on a new paradigm shift that is being advocated over the past several years around a biopsychosocial approach that highlights the unification and interaction of biology and psychology of the individual and social factors of their communities and environments to gain a better understanding of the development and treatment of mental health disorders. As a computer scientist, in the context of emerging research in digital mental health, I will therefore recount some of my experiences of working with different stakeholders, thinking about how technology may help with this unification and how it can inch us towards the new paradigm, the next paradigm shift, while also paying attention to three core underlying principles. First of all, increasing agency of and power to the most vulnerable. Second, preventing unintended negative consequences of the use of digital technologies. And finally, conforming to ethical and compassionate approaches. The first example that I'll discuss is an ongoing intertwined collaboration between our team at Georgia Tech and Northwell Health, which is a very big healthcare system in New York with cutting-edge treatment and research in serious mental illnesses. Our project is called Thrive, where we are exploring how online behavioral and activity-based trace data, such as on social media, such as people's online searches, could provide a new lens and a form of collateral information to assess mental health status, which can in turn help us think about novel kinds of technologies to reduce and prevent significant morbidity and mortality, and importantly, to ensure that at-risk individuals are receiving the timely care and help that they need. In a formative study within our Thrive project, I wanted to highlight one specific question that seeks to examine to what extent patient volunteer social media data can help clinical decision making around relapse. As you can imagine, patients are a very important stakeholder in this research because it is ultimately them whose data will power the investigations and who will ultimately benefit from the models that we develop. Accordingly, since 2018, we have been recruiting 200 patients diagnosed with a psychotic disorder, specifically schizophrenia, half of whom have had at least one relapse-related hospitalization. All of these individuals agreed to share their entire Facebook archives with the research team, thus giving us a tremendous opportunity here to undertake the relapse prediction research question. We modeled this relapse prediction problem as an anomaly detection, where our idea was to identify person-centered deviations in behavior, in mood, and activity that could be clinically meaningful from the perspective of the individual's mental health state and their well-being. Our results were very promising. They indicated that our models could accurately detect a relapse 30 days in advance of the hospitalization for 79% of the cases. What these results tell us is that personalized methods to longitudinally forecast the likelihood of imminent adverse mental health outcomes like a relapse is possible and feasible. This information can now probably be helpful for tailoring treatment, adapting therapy, bringing transparency and patient agency to patient-clinician therapeutic relationships, or to simply reduce blind spots in clinical assessments. All right. So now the second example of the second project I'm going to talk about is based on what is now an 18-month collaboration with the CDC, and our central goal here has been to inform suicide prevention efforts of these federal organizations using social media in conjunction with other kinds of public health signals. You all may be aware that, unfortunately, for the last 20 years, the rates of suicide in the US population have been drastically increasing. CDC reached out to me a couple years back, given the urgency of this public health problem, and because there currently exists a lack of real-time information on suicide fatality trends that could guide their prevention efforts. Moreover, if you look at national statistics on suicide, they are delayed by 1 to 2 years. And currently, it is particularly challenging for governmental agencies for this reason to make timely budgetary decisions, deploy interventions, and adapt policies for improving timely access to care. So to address this gap, in this collaborative research, we have developed a first-of-its-kind machine learning model to estimate weekly suicide fatalities in the US in near real time. What we did in particular was we developed and validated a two-phase machine learning pipeline to leverage many disparate but complementary sources of real-time information, which included novel health services administrative data, economic data, meteorological data, and online data. On combining these data sources using a deep neural network, we found that all of our ensembles of data improved over models that used individual data sources alone. But importantly, our method outperformed predictions that were given by the best performing baseline models, which made estimates based on historical suicide fatality data alone. So what are the takeaways of engaging with this stakeholder? First, as I mentioned before, there is currently no established way to gather real-time national information on suicide trends, which is essential for timely suicide prevention efforts by organizations like the CDC. Our approach uses multiple complementary data sets in the estimation task, which makes it robust against big data hubris, underlying biases, idiosyncrasies, and unique characteristics of any single data source, which are actually known limitations in existing efforts that harness single large-scale online data sources for meeting public health goals. All right. So as a computer scientist of 15 years, I want to leave you with two thoughts regarding the path that lies ahead of us. First, as computational scientists primarily, it is great that we are contributing to this new and fourth paradigm of mental health treatment and care in digital mental health, broadly speaking. But As I hopefully described in the two examples today, our role takes shape, form, and meaning depending upon how we approach the projects and with whom. I suggest that as computational researchers, we invest in synergistic relationships with stakeholders and vice versa, so that the work that we do, it carries through a real-world positive impact. The second thing I wanted to talk about is that as computer scientists, we need to aspire to not just be good researchers who are good in computation, but also responsible researchers. In this talk, I told you two stories about how we can push the envelope towards a new paradigm of mental health by working together with different stakeholders. But beyond these problems and beyond the specific issues that I discussed, there are a lot of things that computational researchers can achieve through a participatory, a collaborative, multi-stakeholder approach. This includes, for instance, making sure that we are thinking about these problems as not just social problems that we are attempting to solve with a technical lens, but also the fact that we are dealing with socio-technical problems. The second thing is that as we do our research, it will be important for us to pay attention to building trust in affected communities. It'll be important for us to support graceful failures when our data or models cannot stand up to the potential use case. It'll be important for us to do no harm, as the Hippocratic Oath goes, or it'll be important for us to gather and provide evidence for what is right, even if it seems impractical or unrealistic at the moment. The question is, what is a path forward in an approach where these questions are not afterthoughts at the end of a research program, but are actually issues we consider built into our very methodologies themselves? So with that, thank you very much for listening. That concludes my talk, and I look forward to interacting with you during the live session.